Good morning. It's a great honor to be here today at this important occasion. It's an occasion to mark really the evolution of human history, and as well as some of the speakers before have said, to look out at what we need to accomplish going forward. I was asked today to speak about why aging must be part of the public health agenda, and I think the illustrious speakers who have preceded me have laid out many of the issues, and I hope that I can contribute now to looking at them in some more depth, but I know that the people who will follow me will add a lot of complementary and important information. We've heard already today about how the public health successes of the last 100 years have really resulted in tremendously dramatic change for all countries of the world. Decreased infant and maternal mortality, decreasing fertility, and decreased mortality at every age have led to an increase in life expectancy, longer lives, and changes in the distribution of age groups in the population. As is well known to this group, life expectancy is increasing around the world, and you can see that on this slide. Worldwide, since 1950, life expectancy has increased from less than 50 to approximately 70 years. And that increase is happening in every region of the world. In fact, it's happening most quickly and dramatically right now in the less developed and least developed countries. Developed countries have had the opportunity to, if you will, to age slowly in terms of the proportion of the population that is older. But in less developed countries, the proportion that is over 60 is, as you heard earlier, is increasing quite dramatically. And in fact, in Latin America, from now through 2050, the proportion over 60 will increase 2.5-fold. So the world is aging, the Americas are aging, and this is a tremendous success, an unprecedented human success. And in fact, we, in all but 3 countries of the Americas through 2050, we will have, by 2040, we will have an equal number of people over 60 and under 15. A tremendous, dramatic change in the balance within societies. In fact, in many countries, we'll have many more older adults than we will have children. And we have the opportunity, and in many countries are even already experiencing, that the older adults who are living are both the best educated and healthiest older adults in the history of the world. So we're entering, if you will, a remarkable new stage of human history, previously unexperienced, and for which we have no roadmaps. We have a lot of perceptions. As other speakers have mentioned this morning, we have this remarkable disjoint, I think, in many situations between what we want as individuals and what we want as a society. In the last 20 years, I have only met 2 people who said they didn't want the extra 30 years or 40 years that we have added to human life expectancy. And their responses were conditional on whether they would be healthy or not. But as a society, our perception is, as this slide shows, that we're very worried. And we anticipate that this immense achievement of humanity, of longer lives, is a disaster for society. But if we go back to who we are and what we want, we still want those extra years. We want them for ourselves. We want them for our parents and grandparents, and we absolutely want them for our children and grandchildren. So are there ways to bring those 2 goals together in a more optimistic frame than our conversation often carries on about? Certainly the Madrid Declaration of 2002, as well as this and other gatherings, has said that forward thinking calls us to embrace the potential of the aging population as a basis for future development and as central to successful development. And that to do that, we have to recognize that older people are an asset for the growth of mature and fully integrated humane societies, as well as for their families. So how could we imagine both shifting perceptions and ensuring a positive reality in this unprecedented stage of human existence? How can we bring out the benefits and fully experience them of our longer lives for ourselves and our societies, while addressing as well the challenges and the needs that come with increasing age? The Madrid Declaration said that we have to turn to building a foundation of a society for all ages, and prior speakers have talked very much about that it needs to include creating new kinds of opportunities to ensure quality of life and well-being for men and women as they get older, and it needs to ensure health, optimizing health as people grow older, and the promotion of supportive environments. So how do we prepare for these longer lives? I would like to say, as others have alluded to, that this is a life course challenge, because there are investments and needs at every age and stage of human existence, so that the children now are aging well in 50 years, so that our societies age well. And while it's beyond the scope of my talk to talk about the investments needed at every age, there are tremendous ones that we need to talk about. But we need to keep in mind the human experience, both for each of us at every age, but also that intergenerational transfers, exchanges are essential to a cohesive and a resilient society. And that we already have wonderful and meaningful roles for older people as caregivers, as grandparents, as our community glue, as our political forces. And we are going to be aging into multi-generational beanpole families, but we need to look ahead to craft the roles and responsibilities and opportunities and meaningful engagement that could bring out the only increasing natural resource in this world, which is older people. So how do we tap the social capital that older people bring in ways that could be transformative and beneficial for them, as our previous speaker said, as well as for all of us? Well, healthy aging is not the only key. Optimizing health across the life course and optimizing people's opportunities to live a healthy life is key. And it's going to require transformations in how we work together and what our approaches are at the social, economic, and health levels. Others have mentioned before me that healthy aging requires a life course approach to prevention, and that is absolutely a public health foundation for ensuring well-being at each age and for ensuring that we're investing at every age in how people will be healthy in years to come. We know, for example, and Secretary Sebelius mentioned this, that, of course, chronic diseases are a worldwide issue. Here you see in orange the total deaths by major cause from chronic diseases in low-income countries on the left, lower middle-income countries in the next set of bars, upper middle-income and high-income countries to the right. And you can see that chronic diseases are the dominant cause of death around the world. We know, and this is a conceptual figure, that the seeds of these chronic diseases grow throughout a life course, from left to right on the chart, starting in young ages, in childhood even. And as you develop subclinical disease, if it gets serious enough, it crosses a threshold where people become symptomatic. how that disease grows at every age and stage matters in terms of when they emerge, in terms of symptoms or even death. And a key goal, of course, is to understand and to modify the rates of that increase in disease. And in fact, that leads, those increased and worsened rates lead to a lot of the health disparities that we see between groups as children grow up and as they get older. Health disparities emerge more and more with later age. A very important study in the United States showed actually that poor African-American older adults, middle-aged and older adults in the inner city in St. Louis had much more disease and became disabled 10 or more years before people who were more affluent and living in the suburbs. So that the rate of aging and the rate of acquisition of health problems varies tremendously across groups, creates health disparities, but also provides great insight into the opportunities for prevention. So investing in health at every age and stage will determine the health with which one arrives at later ages. And in fact, we know that the sum total of those consequences, in large part, emerges as the rates of chronic diseases and geriatric conditions in older people. Here you see a summary of some of the most dominant chronic conditions, from arthritis and hypertension and heart disease and Alzheimer's disease in people 65 and older, but also a mixture of geriatric concerns that emerge particularly in oldest age, such as disability and falls and frailty. You can easily add proportions in the population who have any 2 or 3 of these and realize that people are living with multiple of these conditions as they get older. Interestingly, at every age and stage, health behaviors are key to whether people develop chronic diseases. Well, they're not the only explanation. But smoking, physical activity, and dietary intake at the youngest stages and at the oldest stages, we now know, matter greatly in terms of current and future health status. And we know, for example, that if you look across a range of diseases, chronic diseases, that we not only know better now how to treat those diseases, but we know that prevention works. And for example, something as simple and readily accessible as exercise, remaining physically active, is a preventive intervention that is highly effective for so many different diseases. In fact, some analyses show that tobacco smoking, poor diet, and physical inactivity and misuse of alcohol are responsible for 40% of the total mortality in the United States annually. And conversely, data from the Trust for America's Health shows that preventing these risk factors yields a 6-fold return on investment in terms of economic costs and healthcare costs. In fact, if you look at the U.S. experience in the even over a 10-year period from 1980 to 1990, there was a remarkable 34% decline in cardiovascular disease mortality, and analyses conducted by Hunink and Goldman and colleagues showed that half of that was due to primary and secondary prevention and half to improved care. So that these interventions at every age and stage truly matter. Now, that is thinking across the whole life course. What about for older adults themselves? Do public health goals and prevention goals and health systems matter? And can we help modify whether people live their longer years healthy or ill? Well, a major goal, a public health goal, a healthcare goal, a societal goal in the face of an aging population is to compress morbidity, to push back, to delay the development of disease and disability to the latest points in the human lifespan that's possible so that we can add life to years, exactly the theme of today's celebration. And this truly is a societal imperative to invest in creating those extra years of health in life. Here's a schematic figure that shows why this might matter to an individual. In the top is an example of a person's health status over time, going from birth on the left to death on the right. And this prototypical individual, who, by the way, is a smoker, perhaps develops pneumonia when they're in their 30s or 40s and recovers, and then in middle age starts to develop lung disease, emphysema, perhaps has a heart attack on top of that, but luckily survives, may get a stroke a little later, but survives that, and then develops lung cancer. Every one of these diseases is caused by smoking, although there are other risk factors as well. And you can see that for this individual, they were lucky enough to survive many episodes and have lived with multiple diseases. Now, what if we could delay the onset of many of those diseases till much later in that person's life? They may live the same length of time, but live healthier. What would that mean for society? Well, we're expecting an continued increase in life expectancy. So if life expectancy goes up, will the number of years that people spend in the red stay the same, i.e. disabled or in ill health, in the face of a longer life expectancy? Will we be able to decrease the number of years spent ill or disabled while life expectancy increases? Or in fact, will we increase life expectancy and increase the years of ill health? These are critical issues for individuals as we live longer lives, and critical issues for society. So improving healthy later years through delaying the onset of disability and illness to the latest point in the lives of older adults is an absolutely critical public health and clinical goal for us in an aging society. How we add life to years is the next question. And in fact, we know now much that we didn't know 30 years ago. We know a huge amount about why prevention continues to matter into the oldest ages. Prevention for individuals, prevention in the way we design our communities, excuse me, and our environments and policies. And look at the impact. Again, I can share with you some US data from 1950 to 1997. There was a dramatic decline at the oldest ages, from 65 to 74, to 75 to 84, to 85 and older, in the mortality rates from two of our biggest killers, heart disease and stroke. So we were able to decrease mortality rates at the highest ages. And beyond heart disease and stroke, we know, for example, just going back to health behaviors, that they affect into the oldest ages many of the same diseases that they modify at young ages. In addition, some geriatric conditions like falls and frailty are very dependent on how physically active, for example, people are. But we also know that there are interventions, both medical therapeutic interventions as well as lifestyle interventions, that modify whether people develop diseases in the first place. The diabetes prevention trial very dramatically showed that both metformin, for example, and combined intervention of physical activity and diet prevented diabetes in both middle-aged and older adults, but the lifestyle intervention was actually much more effective than was the drug therapy for older people. Of course, with longer age come serious health issues not often found at younger ages, geriatric conditions like frailty and disability, as well as living with multiple health problems. And this concept of reserves, which previous speakers have mentioned, and the diminution of reserves, which is exemplified in this picture, at younger ages, we are able to maintain a high level of resilience in the face of stressors. But as we get older, our physical reserves diminish over time, and it becomes increasingly important to compensate externally in terms of the supports we have in our daily lives to be able to continue to live independently and autonomously. And disability does increase with increasing age, particularly as a result of chronic diseases, so that people living in the community have difficulty walking, and they can develop difficulty taking care of their tasks of daily life. Because of this expansion of conditions, public health approaches become even more important in older ages and are highly effective. In addition to the primary and secondary prevention of chronic diseases and the treatment of those diseases as kind of a foundation for public health and medical approaches, there are so many other issues which I've mentioned in which supportive care and prevention matter and work. Here, for example, are data from a very important falls prevention trial led by Mary Tinetti, in which she showed that a multifactorial intervention with older adults who are falling decreased risk of recurrent falls by a third. Very dramatic. And there are now evidence-based interventions for geriatric syndromes and many of the challenges of aging that have been shown to improve outcomes. And some of the other people here today, I think, will comment on them. But we have tremendous evidence now that prevention and effective care matter for many of the conditions associated with getting older, which 30 years ago we thought were inevitable with aging and not modifiable. The World Health Organization, of course, has given us this elegant formulation that part of the goal of successful and healthy aging is to help people maintain their independence and to prevent disability into the oldest ages. And we know that it's possible to do for many people, not for everybody, but for many people. For example, going back to just the health behaviors I was talking about, people who smoke, are obese, and don't exercise have a 4-fold increased risk of becoming disabled. And conversely, health promotion programs can postpone disability almost 8 years in several studies. So that it is possible to modify both the rates of becoming disabled and to improve it. So we now know a lot about how to accomplish healthy and positive aging, but how we implement it, how we design the contents of care and the systems of care will matter. They'll matter for the individual, they'll matter for our communities, and they'll matter also in terms of the healthcare costs needed to provide care for people. And that's going to be shaped very much by whether morbidity with aging stays the same, increases or decreases, and how we invest in the prevention and care and correct and best health systems that can provide our investments in health and support the needs of people as they get older. So an older population is going to require new approaches to both public health and healthcare delivery, and perhaps a new vision of what a health system is. Clearly, we know that clinical care for older people benefits from geriatric expertise and competency. But in addition, we know that the locations of care matter, that you have to be able to deliver care in the clinic and the hospital, but also in the community and the home, and to be able to bring services in many settings. And we know that population health approaches matter tremendously as people get older, but also the social institutions that help people remain active and engaged, keep people healthy, and give them a sense of well-being and connectedness that is critical. Social protection systems and how we create them in the history of a nation and how we sustain them are a floor of insurance for well-being in older age, whether it's for us now or for our grandkids when they get older. How we design our cities so that they're age-friendly. How we preserve our environment so that people don't get sick from it. And finally, how we design our policies and norms and regulations to support health are all essential parts of a health system of the 21st century. And I will say, if we design them for the most vulnerable groups, for older adults, we're designing a health system that would be great for everybody. So I'll end with two comments. One is that there are essential components for health preservation at every age, but they matter deeply at the oldest stages. And what older adults can bring to society is enhanced by their ability to remain active and engaged. Certainly, the World Health Organization, age-friendly city key domains are essential. I have the privilege of serving on New York City's own design of New York as an age-friendly city. And it is very clear that this matters tremendously to the older adults in our city. I'd like to end by commenting on one aspect of age-friendly cities, which other speakers have talked about, and that is the issue of remaining active and engaged in one's world. And I'd like to conclude with one experiment which I have had the privilege of designing and spending the last 20 years working on, and that is a program called Experience Corps. Experience Corps was designed to try and create a model for new roles that we need for people as they get older in society, ones that could bring the benefit of the social capital of mature people who want to leave the world better than they found it, which is an enduring characteristic of people as they get older. In this case, a senior volunteer program designed as a win-win to have high impact on children's school success for children in public elementary schools, while also designed as a public health model for health promotion to increase cognitive, physical, and social activity through meaningful and high impact social engagement, and to engage people in enduring ways so that they get a sustained dose of prevention. I don't have time to go through the model or to tell you a lot of the impact, but we will be reporting out this summer the results of a major randomized controlled trial of Experience Corps in Baltimore City in the US. But this is a model designed to create really meaningful, high-impact roles for older people serving in an area that is essential for an aging society, which is to ensure that our children succeed academically. The program actually has been shown in preliminary evidence to improve children's academic outcomes, but it also has been shown to keep older adults more physically active, a 30% increase, for example, in the number of blocks walked per week among Experience Corps participants compared to a control population. But in addition, we designed the program to engage people in things they cared about, but to have roles that were designed to improve their mental function and their memory and their executive function. And I'd like to show you some of the preliminary results of that. Our preliminary data from Experience Corps show that in this program designed to improve memory and cognition, that in the yellow, the intervention group improved just those. And in fact, in the far right bar, executive function improved in only 8 months, 44% in participants in Experience Corps compared to 9% in people in the control group. This is in people who had low normal executive function to start with. And in a companion case control study, what we found is that the brain actually was activated in blue here after only 6 months in Experience Corps participants compared to a comparison group, and in exactly the same areas that their cognitive function improved. Now, this is not a definitive study, but it suggests that brains remain plastic into the oldest ages, and that if we design new kinds of roles for older people that they care about, and we make sure that we do it in a way that is health enhancing, that people's brain function can actually improve into the oldest ages. So the charge and the tasks ahead of us are many, but I think the opportunities are huge. And if we learn how to bring public health both into the clinic, into the community, and into our vision of the roles and opportunities and needs we have for contributions by older adults in the coming decades, we will have an opportunity to create a world of win-wins for all ages and all generations. It's going to require attention to how we create new institutions, new health systems, how we train our health professionals so that we both compress morbidity but realize the benefits of an aging society. Thank you very much.